Good evening, everyone, and welcome to tonight's Scleral Lens Education Society webinar, How to Fit Modern Scleral Lenses, with two very well-respected fitters and presenters, Drs. Dan Fuller and Greg DeNaeyer. First, Dr. Dan Fuller received his bachelor's degree in 1980 from Purdue University and his Doctor of Optometry degree in 1984 from The Ohio State University College of Optometry. Began his career in a hospital-based setting in the U.S. Navy, serving for 8 years. He spent 17 years in private practice as an owner of a multi-site solo practice, emphasizing medical eye care and specializing in contact lens services. His career in academia began in 1987. He holds the rank of professor as the chief of cornea contact lens service and founding supervisor of the cornea contact lens refractive surgery residency at the Eye Center Southern College of Optometry. He lectures nationally, has authored numerous peer-reviewed papers, posters, and performs original clinical research. He's a diplomate in the Cornea Contact Lens and Refractive Technology section of the American Academy of Optometry and a fellow of the Scleral Lens Education Society. He has held multiple chairs of leadership, serving local, state, and national organizations. He is currently the secretary of the Scleral Lens Education Society and on the advisory board to the Gas Permeable Lens Institute. We also tonight have Dr. Greg DeNaeyer, who practices at Arena Eye Surgeons with an emphasis on specialty contact lenses. Dr. DeNaeyer was a co-founder and past president of the Scleral Lens Education Society and is a fellow of the American Academy of Optometry. He is a contributing editor for the Contact Lens Spectrum and a contributor to Review of Cornea and Contact Lenses and Optometric Management. Dr. DeNaeyer is an internationally recognized contact lens specialist, having delivered invited lectures or workshops at over 70 conferences. He has authored 2 scholarly book chapters, 7 posters, 5 peer-reviewed scientific papers, and over 50 professional publications primarily related to complex contact lens fitting. He has also been involved in a number of industry-sponsored trials and contributed to the development of new scleral lens designs and innovative ocular imaging technology. Currently, his primary research is focused on specialty lens design and corneal scleral topography. Dr. DeNaeyer has been awarded the GPLI and Scleral Lens Practitioner of the Year. So with that, I will turn it over to our presenters, Drs. DeNaeyer and Dr. Fuller.
Thank you. I appreciate that introduction. This is Greg DeNaeyer, and with me, of course, is Dr. Daniel Fuller. And I'll be walking through the slides this evening, and Dr. Fuller will be interjecting his expertise as we move along. These are our disclosures. And our objectives for this webinar include discussing terminology regarding scleral contact lenses, deciding who's a candidate for scleral lens fitting, some on basic fitting of scleral contact lenses, as well as troubleshooting, application and removal tips, as well as discussion of solutions. Well, originally the Scleral Lens Education Society was in charge of defining what scleral contact lenses were. And that designation basically broke scleral lens down into 3 different categories, including corneal scleral lenses, mini scleral lenses, and large scleral contact lenses. That has changed in the last year as a paper was published. And the purpose of this paper, the official guide to scleral lens terminology, was to provide some uniformity between scientists and practitioners when discussing scleral contact lenses. And the new definition of what a scleral contact lens basically parallels what our fitting objectives are with scleral lenses. And so the definition of a scleral contact lens is really a gas perm contact lens that vaults the cornea and lands on the bulbar conjunctival scleral surface. So in some essences, it's been quite simplified. Scleral contact lenses are unique to all other types of contact lenses because they semi-seal to the eye, which allows them to hold a fluid reservoir. And that fluid reservoir is able to mask both regular and irregular stigmatism, but we're also able to use that fluid reservoir to help treat patients and manage patients with ocular surface disease. As compared to corneal gas perm contact lenses, the diameter of a scleral contact lens allows it to have significantly improved centration, stability, and provide patients with relatively more comfort. And that's really why scleral contact lenses have become popular in the last 10 or 15 years. Both practitioners and patients really find more success with scleral contact lenses, especially for challenging cases. Well, one of the first aspects of learning how to fit scleral contact lenses is deciding who would benefit from scleral contact lenses. And by far, the primary category for fitting scleral contact lenses are for patients who have corneal irregularity. And in fact, we know from scope data that was surveyed in 2015 that for the category of corneal irregularity, 97% of scleral lens fitters responded that they use scleral lenses for fitting keratoconus. So out of all the conditions that we could use and fit patients for scleral contact lenses, keratoconus is definitely the primary category of patients. And when you think about your practices and increasing your volume of scleral lens fitting, this is a category that you want to target, keratoconus. The second primary category of patients that we would use to fit scleral contact lenses and manage patients are patients with ocular surface disease. So these are patients with disabling dryness. Typically, these patients will have a primary systemic condition and then develop this severe secondary ocular surface disease. Many times, these patients struggle despite maximum palliative care or medical management. And scleral contact lenses are able to provide protection for these diseased ocular surfaces and really help change these patients' lives. And so this definitely is the second category of patients that you would use to fit scleral contact lenses. And in my opinion, this is an underserved category of patients. So again, getting back to your practices, this is another targeted area of patients that you can provide care for. Well, worldwide, the vast majority of scleral contact lenses are fit using diagnostic lens sets. So we'll spend the bulk of our time for this webinar talking about diagnostic lens fitting. And we use diagnostic lenses to determine the sagittal depth necessary to vault the corneal surface. We use the lenses to determine geometry for fit. We use diagnostic lenses to also determine the type of landing zone that will best fit our patient. And finally, of course, we use these lenses to determine the power that's necessary to provide the patient with their best visual acuity potential. Now, using diagnostic lenses is really more art than science, and there's certainly a steep learning curve that definitely challenges the novice fitter, but as well can challenge even experts for difficult cases. And this was a study presented as a poster first at the Global Specialty Lens Symposium and then later as a paper that looked at what the learning curve was for a novice scleral lens fitter to become proficient with scleral contact lens fitting. And what the study found was that it took approximately 60 cases to become proficient at fitting scleral contact lenses using diagnostic lenses. And you can imagine that if you're only fitting 2 to 3 lenses a month, that it could take you 2 to 3 years to become proficient at fitting. We're going to talk later in the webinar about ways that we can reduce that learning curve. When we assess a scleral lens on the eye, we're going to break the lens into 3 zones. So we're going to break, the first zone is the central zone, and then around that we have the limbal zone, and then finally the landing zone. And you'll see as we move through the slides that we're going to assess the lens from the inside out. So starting with the center and then moving out towards the periphery. So we'll start with the central zone. And essentially what the central zone is, we're trying to determine the amount of fluid reservoir or vault over the cornea that's going to best fit the patient. As I stated earlier, you're going to use the diagnostic lenses within your fitting set to determine the amount of sagittal depth that will properly vault the cornea that we're fitting. Essentially, we're trying to come up with a sagittal depth that is a few hundred microns more than the sagittal height of the diameter of the eye that we're fitting. Well, one of the first questions that any particular practitioner may have when they start fitting scleral contact lenses is where to start in your fitting set when you have a patient in the chair. And certainly most of the designs will have fitting guides that will have some formula to get you started. Typically that may use simulated Ks. In all reality, these formulas aren't very accurate, but what they do is they get you to put a lens on the eye. And from there, that's how you really make the assessment of the fit and know where to proceed accordingly. So for example, this is a fitting set of scleral contact lenses. And most of these sets are going to increase in sagittal depth as you move through the set. So for this set on the top there from left to right, we have lenses of increasing sagittal depth, and that continues then as we go towards the bottom of the fitting set. And so if you're unsure about where to start, one of the best things to do is just start with the middle lens. So you're going to put that first middle lens on the eye. If it's too flat, then you can always go steeper, or if it's too steep, then you go flatter. If you have a patient that you already know has a fairly steep eye, for example, a keratoconus patient, then you could start steeper in the set. And then of course, alternatively, if you have an eye that looks relatively flat, for example, the patient might have had a corneal transplant or post-myopic refractive surgery, then you may want to start just a little bit flatter in the set. But really, and most importantly, you just want to get a lens on the eye, and then you're going to use that lens to guide you for your next lens selection. Well, when we talk about sagittal depth of a scleral contact lens, there's two primary parameters that we would use to vary sagittal depth, and that is diameter and base curve. And really, when we increase the lens diameter, we're increasing the lens's sagittal depth. With base curve, it's the same. When we increase the steepness of the base curve, we're increasing the sagittal depth of the contact lens. The opposite is true, of course. We decrease the sagittal depth of a lens by decreasing diameter. We decrease the sagittal depth by flattening the base curve of that scleral contact lens. Well, once we have chosen our diagnostic lens, the first thing that we need to do is actually fill the lens with non-preserved saline solution. And it's helpful, I think, especially if you're a beginner with fitting scleral contact lenses, to stain that saline solution. And typically in the office, what I do is I just use a fluorescein strip to dip into that saline-filled scleral contact lens. And we can use that, as you will see, for lens assessment. So starting with the central zone, what we're trying to achieve is a central vault of approximately 1 to 200 microns over top the cornea. And in the slit lamp, after you put the lens on, there's a couple of ways to try to assess the central vault of that fit lens. You can either use diffuse illumination, and then we can use a slit beam. With diffuse illumination, remember we've stained that fluorescein, or we stained the saline with fluorescein. We can use our cobalt light and filter to assess the lens just more generally. So for example, the lens fit on the left is a lens, scleral contact lens, that is mildly flat fitting on a patient with keratoconus, who has central keratoconus. And so for this fit, if we put a lens on that eye, we get this pattern, we need to steepen the fit, probably by 200 or 300 microns. What we're trying to achieve is like what we see on the right, where we have a diffuse pattern of fluorescein without any touch. Dr. Fuller, can you go over how we would use the slit beam to estimate the amount of microns of our central vault, our fluid reservoir?
You bet. Thank you, Greg. It's always been challenging, I think, for folks first starting out, because they know that the corneal thickness in a normal eye is about 540 microns or so. And so there's a tendency to want to use that thickness of the cornea to measure the depth of the reservoir. We can't really do that because most of these eyes, as Greg pointed out, are irregular corneas, and most of those are going to be keratoconic eyes where you've got some ectasia or thinning going on. So you need something that's a fixed measurement to use as your biometric ruler, and the simplest, easiest way to do that is to take the center thickness of your lens, and that presumes that you know it, so it's important that you document your parameters fully within your record, and take the information off your invoices and document that fully so that you have that information. And assuming that you're going to be in that, anywhere from say 200, 250 to as much as 400 or more if you're dealing with a plus thickness lens, say in a RK patient or an aphakic, you have to know that center thickness. And assuming it's a pretty normal 300 or so micron, 400 micron thickness, you want to be somewhere in that 80% thickness range for the scleral reservoir as well, for the tear reservoir. So looking for something close to a 1-to-1 is not a bad place to start. And we'll talk about settling in just a moment. But when you first put it on, if you're a little bit strong, that's okay because it's going to settle, but you don't really want to be much more than about 400 microns or so, because then the optics are degrading, and going from about 300 to 400 microns, you lose about 30% of the oxygen transmission based on some recent information that we have. The other thing I would caution is, as we looked at those overviews, if you have your slit beam off to the side, you'll notice that you get some shadowing on the opposing side. So if you've got it off on the temporal side, you'll see a little shadow on the nasal side that may be misleading. So it's important that you sweep your beam across before you make a final judgment on how things are fitting across the whole diameter of the lens.
Thank you. Well, when we talk about estimating the central corneal clearance, Amy DiNardo from Ferris State University a couple of years ago did a study surveying both novice fitters and experts, and basically testing them on their ability or accuracy of estimating central corneal clearance. And as it turned out, most of the responders didn't do very well or weren't very accurate with estimating central corneal clearance. However, what she did find is that everybody improved in their accuracy of estimating central corneal clearance by using a fitting guide. So Ferris State University came up with this fitting guide that you can find on their website. You can either download it and use it electronically or print it out. And using this as a guide, you can more accurately in your clinic lane estimate the amount of clearance that you have for any lens that's on the eye. The most accurate way to determine the clearance of a scleral contact lens is to use OCT. And after you take the OCT, basically you're going to use the calipers to measure in microns the amount of vault. And a real fitting tip here is that as you go through and put several lenses on the patient's eye, it would be my recommendation not to OCT every single lens, but you want to use this slit beam estimation method that Dr. Fuller was discussing. And then when you get the best fit lens that you think is closest to what you need, that would be the lens that you use to measure with the OCT.
And Greg, if I could interject there,
Yeah.
on the estimating part of it, it was interesting that one of my previous residents and I had done a study of these types of things too, after we had seen Amy's poster at the Academy. And one of the things that we found is that there's a directionality to your error. So practitioners, particularly neophyte practitioners, tend to overestimate the amount of clearance that you have. And as that clearance becomes less, the magnitude of your error in the overestimating becomes greater. So be aware of that you're more likely to fit a lens in too shallow a manner than to fit one that's too steep.
Yeah, that's an excellent point. I know I make that error myself for sure, especially as I compare that to OCT. Now, as Dr. Fuller had mentioned earlier, that we can have some lens settling once we put the lens on the eye. The scleral contact lens doesn't really rest directly on the sclera, as its name implies, but it's actually resting on the bulbar conjunctiva, which is spongy. And what we can see as the lens sets on the eye is that we can see both short-term and long-term settling into the eye. And as the lens settles, we're going to lose fluid reservoir. We're going to lose vault. And so we have to factor that into our fitting process. Now, most of the studies that have been done and they're out there focus in on short-term settling. And we have some of those to the right there. The average amount is approximately 100 microns, although that third study, the range was up to 186. But for me personally in clinic, to take into account both the short-term and again, potential long-term settling that can happen months down the road, I tend to expect to lose around 200 microns of clearance. And with that in mind, if I want to reach a vault of, let's say, an ideal vault for me would be 100, 200 microns, but let's say I want for one particular patient 100 microns, that means that when I first put the best fit diagnostic lens on the eye, that lens really should be around 300 microns of vault. And then I'm thinking, or will know that as the lens loses vault, that I'll still be left with at least 100 microns. What's your philosophy, Dr. Fuller?
No, I would agree with that. There's been different things reported over time. Some will add as much as 350 microns, but I'm kind of with you in that same camp that allowing about 200 extra for most of the scleral lens designs that we're fitting seems to work out about right.
Okay, that's great. Well, just to summarize the central zone, because this is one of the bigger factors of the lens fitting, we're going to use a series of diagnostic lenses to determine the vault necessary. We're going to bracket those lenses. So for example, if you put a lens on that's a little too flat, like we saw earlier, you don't want to necessarily grab the next lens in your fitting set. My recommendation would be to go up a few lenses, 200 or 300, 400 microns, and then work your way back down. That will improve your efficiency. We're really looking at the end after settling for the lens to vault or have a fluid reservoir of between 100 to 200 microns. This will maximize oxygen to the cornea, as it's been shown that the reservoir may be a resistor to oxygen. And then also, this is kind of a helpful tip here, in that there was a study that showed that approximately 50% of lens settling occurs 30 minutes after application. So one method could be that you put the lens on, you could take an OCT, wait 30 minutes, take another OCT, and that may give you a more accurate estimation of how much that lens is going to settle over time. Well, the next zone is the limbal zone. And when we would look at a fit scleral contact lens, that scleral contact lens should vault that limbal area by between 25 to 75 microns, ideally. What we don't want is the lens to rest or to bear down on the limbus like we see pictured to the left. In fact, actually, some of the most severe complications that I've seen from scleral lens fitting have happened because of this type of fit. In fact, chronically worn, when a lens is bearing on the limbus, will get severe limbal keratitis and neovascularization. Now, we have to contrast that with lenses that will sometimes decenter. And so, for example, this lens to the right here, we see some limbal touch here, but it's only in one quadrant. And that's a result of the lens settling down and out, which is common with scleral contact lenses. Most of the time, this will not be an issue. It's where, like we have on the left, the lens is basically bearing down on the limbus in a circumlinear fashion. And really, when you think about it, the lens designs that are out there as diagnostic lenses, they are designed to vault corneas with average diameter. So corneal diameter really is the anatomical factor that determines limbal vault. And you're most likely going to be fine if the patient has an average corneal diameter. Where we're going to see cases of limbal bearing are for patients who have extra large corneal diameters. And we're going to have Dr. Fuller kind of walk you through diameter selection, taking that into account.
Thanks, Greg. And I would agree with that. The only other time that I see some of those things happen, and they're kind of the bane, I think, of all our existences, and I don't know about you, Greg, but the RK patients are particularly difficult sometimes to fit because of their more oblate shape, and also decentered grafts can be a problem. Those would be two other categories of fits, I think, that I've wrestled with on those kind of things. Jan Bergmanson is a fabulous researcher down at the University of Houston and heads the Texas Eye and Research Technology Center there. And what his background is basically in anatomy. And what Jan will tell you is that the limbus is not one zone or one point. It's actually a fairly wide zone. And you can look now with the use of OCTs, anterior seg OCTs, and see that the correlation between where the clear part of the limbus starts and where you can see the haze of the sclera beginning does not overlie the insertion of the iris root into the angle all that well. So he would tell you that it's really a zone that's approximately about 1.2 or 1.5 millimeters or so wide all the way around the circumference of the cornea. So we use terms like HVID and white to white and other ways of trying to describe that. And we know that it's not a perfect circle. We know it's kind of a horizontal ellipse as well, which kind of complicates things when you're fitting circular shaped lenses on a oval ellipse like that. So those are some things to think about. And as Greg had talked about, the average sort of corneal diameter is going to leave you with these kind of relationships that you can see there, that most of the time, most of the folks will do fine in and around the 16.0 to 16.5 diameter lens to start with. And the scope study shows that. We've got a couple research papers out right now that have demonstrated that as well in our own files. So that's not an unreasonable starting point. But Dodi Ferdel out of Italy had written a paper on this a couple years back. And what she had suggested is that you take that horizontal visible iris diameter and add either 3 to 4 millimeters to it to give you the appropriate clearances on the limbus and to give you a soft landing into the landing zones as well. And you can certainly check those clearances with an OCT just as you can the central clearances as well. Be aware that, as Greg pointed out, that if for the same base curve as you increase the diameter, you're increasing the sag. So not every set allows you to vary the parameters on your lens independently. I tend to favor sets where I can vary those independently, but some of the sets you have to be careful, because if you do change something out in the limbal zone, you're going to change something in the central zone, and so you have to constantly go back and recheck your fit as an iterative process to get to the optimal fit before you get done. But the optimal lens diameter is going to be that one that allows you to clear the limbus and maintain that sagittal relationship in the center that Greg talked about.
Okay, great. And just to keep in mind too, there's a number of ways to evaluate the fit at the limbus using your slit lamp. So one is just diffuse illumination, like we see up and to the left. You can also just use diffuse white light. So we see this photo up and to the right where we can actually see fluorescein being diffused down below the limbus. And then also, finally, you can just, again, use your slit beam like you did centrally, but just out to the limbal area. And of course, just like in the central zone, we can also use OCT to try to determine if we're getting a vault over that area, especially if it's tricky, if you're having trouble reading the fluorescein pattern. This is something good to use. You certainly don't need an OCT. In fact, I would rarely use it because it's you're measuring one meridian at a time, and this can take some time. So just use it if you need it. If you're questioning what you're seeing at the slit lamp, this can be a good way to check to make sure you're clearing that area. We're also going to use scleral lenses to help us determine the best geometry that is required to fit a particular patient. And so we talked that a lot of these patients are going to have corneal regularity. They may have different corneal geometry. So we have normal prolate corneas. Those might be patients that just have a mild corneal scar, but a prolate cornea, steep in the center, gradually flattens out to the periphery. We have our ectatic eyes, which I would call sort of ectatic prolate. So they're prolate, but they're more steep in the center or inferior area of the cornea. And then we have our oblate corneas, which can commonly occur after a corneal transplant or especially after a myopic refractive surgery. And the idea is that you want to match the geometry of your lens design with the patient's cornea, because that allows you to more evenly vault from limbus to limbus. You don't get larger areas of vault in one quadrant and less in another, although especially with keratoconus, sometimes that eventually does happen. Some designs out there basically are designed to fit either oblate and prolate, so one lens design fits both. And then you'll notice that in some of your fitting sets, they actually have separate lenses. So they have lenses to fit prolate eyes, they have separate lenses to fit oblate eyes. The last parameter, main parameter, besides power that we're going to talk to you regarding fit using diagnostic lenses is the landing zone. And with the landing zone, there's four main types of lens design. So we can think about the landing zone, and this is the part that lands on the scleral bulbar conjunctiva, of having a spherical design. We have lens designs that will be toric, that differ in primary meridians of 90 degrees apart. We can have quadrant-specific designs as well as free-form, basically completely customized landing zones. We'll talk more about that as we move through these slides. The landing zone of the scleral lens should rest evenly on the sclera without compression, impingement, or edge lift of the bulbar conjunctiva. So, you should almost hardly see the lens on the patient's eye. This is a patient of mine, well fit, very even landing zone. We don't have any compression. We have a little bit of conjunctival prolapse in the inferior quadrant, but otherwise a really terrific fit. It's important that when you get the best diagnostic lens on the eye with regarding central vault, that we let the lens settle for approximately 30 minutes, because that will give you the most accurate depiction of how that landing zone is fitting on the patient's eye. What we want to avoid, number one, is lens compression. So this is where the lens is really fitting too tight on the eye. There's a lot of compression. This will be very noticeable because there'll be a lot of redness. We have areas of blanching out to the side here. You know, these lenses are really unwearable. The patient will be very irritated with the lens, and the lens will be very difficult to remove. So at this point, you either have to really work with the lab and flatten that landing zone out, or sometimes you just even have to switch lens designs. Now, if we look at this case example here, this is a patient of mine that I put their lens on the eye. It looks actually fairly compressed, so it looks like it's too tight. However, you have to be careful because this would be the lens fit 30 minutes later, and now it really looks like it has a nice even fit. And what happened here was that when I applied the lens to the patient's eye, I just applied it with a little bit too much pressure, which gave us this real pseudo compression of the lens fit. So another reason, just let the lens settle, and also just, you know, make sure that you more gently apply the lens on the eye, because if you think or don't take into account lens settling here and some time, you may flatten this lens design on a lens that really doesn't need to be loosened or flattened.
I just want to say kudos to you, Greg, for doing that, because we got caught on that when we first started fitting these things fairly commonly. And we had patients that would come in the same way, and they were really pushing the button, trying to get the lens on the eye, so to speak. And I think we learned from that the same thing, and also learned that it's important to see your patient handle their lenses at some point in the follow-up visits too, to make sure that they're doing it well.
Absolutely, absolutely. And you know, we have some research now on scleral shape. This was a paper that was published a few years back with the objective of determining or categorizing scleral shape. And when we look at those lens categories and we're able to match them up with lens design, what we find is that for any patient that reports for scleral lens fitting, approximately 6% of those patients will be best fit with a landing zone that has a spherical design. 30% will be best fit with the landing zone that has a toric design. And then, you know, maybe surprisingly, 65% will actually be best fit with an asymmetric design. So that would include a quadrant specific design or a freeform lens design. And if you don't have scleral topography or an instrument or a way to measure the sclera, I think one useful way to try to determine scleral shape is just to put a spherical lens on the eye and evaluate the landing zone. So for example, this patient, we apply a scleral lens with a spherical landing zone. At the inferior and superior quadrants, we see fairly good alignment, but as we go out horizontally, we start to see some compression. And because this is symmetric, we can assume that this patient has a toric sclera. And so what we want to do is we want to use a design that is a toric landing zone. And what's great is many of the diagnostic lens sets now have separate lenses in the set that have toric landing zones. And I think a question is, well, how much, you know, if I see this pattern, how much toricity should I start with? Well, approximately, it kind of depends on diameter, but approximately the average amount of scleral toricity is about 200 microns. So that's always a great place to start. We want to look for the markers and see where the lens is orientated, where it's flat or where it's steep, because this information will be useful later if we're going to add either front surface toricity or, for example, a localized vault. We have to measure where that lens is going to orientate. You can either use clock hours or degrees. And when we pass that information along to the manufacturer, this allows them to know where to put more of these customizations onto the surface of the scleral contact lens. Quadrant-specific designs or freeform landing zones might be necessary for asymmetric lift like we see in this fit here, or localized impingement. So where we see areas of impingement, compression, or lift that aren't symmetric, this is where we may need something more customized, a lens that either has a quadrant-specific design or freeform. Commonly, we can have impingement of the landing zone secondary to pinguecula. So pingueculas are quite common. And unfortunately, if we do get impingement with a pinguecula, this will cause the patient irritation, decentration, and edge lift. And I think commonly now, one of the best ways to deal with these is to create a localized vault. This is a little bit more advanced, and we don't have time to go over the details on this, but we just basically create a vault that will line up with that pinguecula and vault over that surface. And then, really finally, after you have your assessment of the lens fit, we need to figure out power. And we do that by using our best fit diagnostic lens and completing a sphere sill over a fraction of that lens. Sometimes we may have residual astigmatism, and that we want to add front surface toricity. If we do that, just like our soft toric lenses, these lenses have to be rotationally stabilized. If we're using a spherical landing zone, then we may use something like double slab off. And other manufacturers will call that different names, but it's just a way to orientate the contact lens in a rotationally stabilized way. Or we can stabilize it using customized landing zones with toricity or quadrant-specific changes or freeform lens designs. This allows the lens to lock into place, and then we can add that front surface toricity into its correct orientation. I want you to be cautious about adding front surface toricity for patients with keratoconus. Oftentimes, patients with keratoconus, even with the best fit scleral contact lens, will have residual coma. And sometimes patients will start taking a toric correction to help correct for the coma. But in my experience, that doesn't really translate well, especially when you order it. And so most of the time for keratoconus patients, unless it really functionally improves their vision on the eye chart, I'm leaving that out. And then that's a great segue for, eventually we're going to more commonly add wavefront correction. So that will correct for that residual coma or even any residual astigmatism.
And I would throw out for our listeners on that point, Greg, those are excellent points that most of the manufacturers too will tell you that unless they have 1 1/4 diopters of residual astigmatism or more, it doesn't profit you much to try and correct that either. And for all those reasons you pointed out so excellently.
Okay, I think we were going to try to take a couple minutes for questions.
Yeah, we've got a few here, definitely. Thank you guys so much for some great information so far. First one, what is the best possible way to improve a tilted scleral fit? I guess one that's not centered up either vertically or horizontally.
Yeah, I think there's a couple systematic steps I kind of go through when I assess that. First, check your central vault. If you have 400 or more central clearance, there's a good chance that you may be loosening up your fit a little bit, and that's common to have them kind of sag down and out like that. Also, if you have an excessive amount of limbal clearance, you'll loosen your fit up. If you're dealing with spherical landing zones, that's probably the easiest way to approach it. If you're starting with that and you're having tilts like that, again, these tricks that Greg just talked about as far as having customized sort of scleral landing zones are important. So you can go to a toric landing zone. That oftentimes will help you more closely align those toric scleral shapes that Greg pointed out with the research from the scleral lens shape study group. And also look at the diameters again too. You may do better with a little smaller diameter than a larger diameter if you have an excessive amount of overlap where you've got something more than maybe 3 millimeters on each side or 4 millimeters on each side. You're probably getting pretty large at that point. And those are some of the key tips, I think, is kind of customizing those parameters. For the advanced people out there, using profilemetry like SMAP 3D or even iPrint Pro to get a more customized fit to align the sclera can help with those tilts like that as well.
You guys had mentioned that settling may occur most aggressively early within the first 30 minutes. A couple questions. Is there big differences in lens design, like say diameter, in the way they settle that's predictable? And then should over-refraction be done initially or after settling?
That's an interesting point. There is some controversy about whether small diameters or large diameters settle more or less, and there is some conflicting evidence in the literature on that. Some folks have tried to approach it as a physics problem that pressure equals force per area, and so if you have the same amount of force and you're concentrating it over a smaller area, like with a smaller diameter lens, you might predict that those would settle more. But there's so many other factors that come into play, I think, in terms of how we're clearing central and limbal zones, and also whether we're using spherical or toric landing zones as well. So it's a little bit difficult to say right now because there's so many variables that confound that decision making. So there's not a clear consensus, I don't think, on that point out there. But Greg, feel free to jump in, and Drew too, you if you want to jump in. As far as doing the over refractions, yeah, absolutely. I like to let those settle. You don't want to rush those. This is not a soft lens fit where you throw it on and maybe wait 5 or 10 minutes on a toric fit to get your residual astigmatism and work your cross-cylinder problems. This is exactly why we'll tell our patients to come back to the progress visit with the lenses on for at least 2 hours before we see them in the progress check when we think we've got a good lens or we're dispensing a lens for the first time. And we do over refractions at each of those visits as well.
A couple things further on over refractions. First off, do you do them in a phoropter or free space? Any difference there? And then Greg, you had talked about why you may or may not use front surface toric over, say, irregular corneas. Maybe you would over regular corneas. Can you kind of revisit that for a second, based on aberration, things of that nature?
Yeah,
Greg, go ahead, Greg. Let you
I'll take
that
second question. And basically, yeah, again, with keratoconus, the scleral contact lens is masking the front surface irregularity. And, unfortunately, as it turns out, the cornea has, of course, a front and back surface. And many keratoconus patients, even with the best fit scleral contact lens, end up stuck, somewhere around 20/30 or so, 20/40 sometimes. And you may wonder why that is, despite the fact that maybe the patient doesn't really have any corneal scarring, that the cornea is actually quite clear. And most of the time that's going to be because once you've masked the front surface irregularity, you're left with irregularity from the back surface, which typically would be positive coma. And that's interfering with their vision a little bit. Now, again, if they're starting out 2400 best corrected and you get them down to 20/40, that's 10 times better. I mean, most of the patients are going to be quite happy and satisfied with that. But again, as you're doing the over-refraction, some of these patients that have this residual positive coma will start to take some cylinder, and it's kind of a way that they're trying to also use subjectively to help mask some of their coma. But again, in my clinical experience, unless I'm really seeing a two lines of improvement, maybe a solid line of improvement, I'm really not going to add that into the toricity, because ultimately two patients will then, later on could do worse. You can over refract them with the dispense contact lens, and then they kick the cylinder out. So it can be some back and forth. Now it's a different story if you have a patient, for example, who doesn't have keratoconus. Let's say they a corneal scar, but they might have a toric IOL in their eye. They're going to have residual toricity that they'll definitely benefit from a front surface toric contact lens. So I think you just have to pick the patient of when you utilize front surface toricity.
I think those are excellent points, and a shout out to our colleagues down at the University of Houston, again, where Jason Marsack and Ray Applegate and Matt Kaufman are looking at creating these wave error correcting scleral lenses to address exactly those points that Greg made, and so stay tuned on that. And some of the work that they did was rather interesting because they found out that it may be more about the contrast that the patient sees too, that they'll be willing to accept a fair amount of defocus as long as they're getting a higher contrast value out of it. So we don't know all of what we need to know about that, and it's a fairly complicated discussion for another day, but just know that there's all kinds of exciting things in the pipeline.
Great, and we'll do one more here. We have a lot of questions that have come in. A lot of them are for individual kind of cases, questions about individual patients. We'll try to address those privately. The last one we'll cover here before we get back to it. On conjunctival prolapse, if you guys want to speak on how common it is, what some remedies might be, and how concerning it would be to you guys when you see it.
Yeah, very interesting situation again. I think the debate that we've had in the Scleral Lens Education Society and different research groups and speakers at GSLS, which is a fabulous meeting, by the way, for anybody that's interested in integrating this into your practice, goes something like this, that as far as actual prevalence and incidence of these kind of things, it's hard to really peg a number, but it's more common if you've got a lot of excess limbal clearance for sure. And any potential space like that is more likely to, and I'll say suck in air quotes, suck the conjunctiva in underneath the lens. It also depends on the patient's characteristics. If they have a lot of conjunctival chelators to begin with, they're more likely to do that. I have had some patients where I've tried to get my fit perfected and I was still getting the problem because the overlying bulbar conjunctiva was just so flaccid, it was so easily migrating in underneath that just the fit alone change wouldn't make a difference. And so you can talk to your local ophthalmologist into doing a little electrocautery on the conjunctiva under just a topical anesthetic. It's done very simply on a clean field in the office, 7 to 10 days healing. They're back to the lenses, and sometimes that's enough to tighten up that prolapse, and it's always down below like that. You rarely will ever see it up above or any other zone of the cornea. As far as the long-term consequences of it, there's some debate about it. We think that it's more concerning that if you take the lens off and you take a cotton-tipped applicator and you try to roll the conjunctiva back, if it's really strongly adherent there, there's some concern that you may get neovascularization and keratinization of that overlying bulbar conjunctiva, and obviously that's not a good thing when you're doing that to your limbal stem cells and the palisades evoked there. So, you know, a little bit of it that quickly relaxes after you take the lens off, I don't think many of us are too concerned about. If you have an awful lot of it, then I think you probably ought to reassess your fit or maybe the design of the lens that you're using. And certainly on those cases where it's adhering, you need to rethink what you're doing.
Great. Well, I think we'll save some questions for the end and let you guys get back to it. Thank you so much for that information.
Well, we have about 10 minutes of material left, and you know, sort of the future of scleral contact lens fitting, and really the future is now, is profilometry, or measurement of the cornea and the sclera, and using those measurements to design scleral contact lenses. And there's a variety of ways to do that. We have corneal scleral topographers, we have Scheimpflug tomography, we have impression techniques. Within the instrumentation category, there's several instruments that we can use. And I'll have to say that without a doubt, this is a way to significantly increase your efficiency and success with scleral contact lens fitting. And it's hard to imagine that, you know, 5 or 10 years from now that most practitioners will be fitting lenses with diagnostics, because we decrease this learning curve that we talked about earlier with the 60 cases. Once we're able to measure and we can design lenses virtually, this really helps improve our success. And in fact, actually, even for this patient with graft versus host disease that had post-tube shunt surgery, we're able to fit this patient, with almost basically one lens, and it's a very complicated fit. And this is done using scleral topography. And as well, this is a dry eye patient of mine who had a conjunctival bleb after trabeculectomy. And again, very complicated fit. We're able to successfully fit that lens to the patient's eye, and that is straight from measurement. So I really think that as we move forward, that's where we're going to go. I don't know what Dr. Fuller's thoughts on that are.
I would agree with that totally. I mean, it's one of the things that you have to bear in mind is that the apex in, say, keratoconus patients is not always in the center of the cornea. And so if you've got a pellucid or you have a really decentered apex and you're trying to get 200 microns of clearance over that apex, say, you're going to end up with maybe 600 or 800 microns of clearance around the base of the cone somewhere else. And having that uniform tear reservoir thickness really helps with those centration problems that we had been discussing, and really gives the patient better optics, because we all see better when we look through the optics the way it's intended on a centered lens than if we're looking at a decentered lens.
Absolutely, absolutely. Well, just a few items on application removal solutions. Most patients are going to use a plunger, or they can use a tripod method to balance the lens. As we talked about, these lenses have to be filled with saline solution. A lot of practitioners use off-label Adipac solution, 0.9% sodium chloride solution. It's non-preserved, doesn't contain any borate, so it's usually very gentle on the eye. But there are some commercial available solutions out there that also a lot of practitioners really like and have had very good success with, including Lacropure, Scleral Fill, and Neutrophil solutions. You have to be really careful about what patients put in the bowl of their contact lenses, because anything that's preserved can eventually lead to either toxicity or long-term hypersensitivity. This is a patient of mine that over months developed a sensitivity to a soft contact lens multi-purpose solution that he started using to rinse his lens off with, and really created a problem for his cornea. And actually you can see that he's had some allergic response on his lid as well. And so I think the important point too is that every time the patient comes in, you should be quizzing them about what solutions they're using, because you may discuss and prescribe solutions, but in the interim, as the patient goes about and starts wearing the contact lens, they may add solutions on their own that can create trouble. And be careful of the sensitivities, because those are always tricky. Those can develop over months or sometimes years of time, and that's where it can make troubleshooting difficult, because the patient may say, well, I've been using this for 6 months and I've never had trouble. Well, it can take that long for that patient to reach a threshold of sensitivity where it creates problems. So always educate your patients, probably at every visit, about the solutions that they use. I'm a big believer in using adaptive devices for application. I have a lot of patients who are elderly or may have some disabilities, and I'll tell you, at least twice a month, these types of devices that really are stands and also have lights to them can really be successful. In fact, actually be the difference between success and failure. This is a patient of mine that is using this tea light, and what we've done is we added the plunger onto the tea light to create a lighted stand. And I got actually this idea from Dr. Bruce Baldwin. He posted this online. I thought this was a great idea, very cost effective, and I use actually quite frequently now. This is a patient using the stand, and she had difficulty just using the plunger alone. So with the light, she can visualize that lens all the way in, and then she's just going to lower her eye onto that filled scleral contact lens. You can see she's reached the saline there. She's going to push a little bit more, and then eventually release her lids and sit upright. And for this patient, again, honestly, the difference between success and failure. And so please use those devices as needed. For scleral lens removal, we're often using plungers. And I mean, I guess the biggest take home here is just make sure you're plunging to the side of the lens, so you lift that edge up first to release the suction. I'm a big believer in hydrogen peroxide solutions because we get away from the preservatives, and I add extra strength cleaners as needed, depending on the patient, depending on if they're a depositor or not. We said that we use scleral lenses to manage ocular surface disease, and so wetting, especially for those patients, can be an issue. And you know, if the lens isn't wetting, you can have the best fit scleral contact lens on the eye, and if they can't see, then you're not going to be successful. And so I have used some surface coating. We now have this tangible HydraPeg surface coating that we can add to our scleral lenses. And I don't use it for every patient, but there are patients like this patient with graft versus host disease. Their lens fit is on the left. It wasn't wetting. We added the HydraPeg treatment to the right. And again, this treatment really was the difference for this patient between success and failure. And she did quite well with that HydraPeg treatment. You know, at the end, we give the patients a kit with all their solutions and devices, plungers, stands if they need them to take home, so that way they know what to use and what to buy. We also provide them with a folder that has all their follow-up instructions, a review of instructions of what we discussed and train them on, as well as frequently asked questions, and also a sheet on contact lens health and safety that we give to all of our patients to make sure that they're practicing healthy, safe contact lens use. I don't know if Dr. Fuller, did you have anything to add to that?
Yeah, I would be remiss if I didn't at least make a passing comment about infection control in these COVID days. That you know, we like to tell the patients to wipe down their plungers with alcohol pads after they're done and let them air dry. And replace those about as often as they would replace their cases. And I'm a huge fan of ClearCare and peroxide systems in general as well. And so, you know, they should be replacing their cases about once a month with those systems, but certainly no longer than every 3 months. And when they're using the stands and that sort of thing, you know, it's good to have them maybe bring them with them, because some of those things get pretty corroded and gummed up. So teaching them how to clean those things is an important part of dispensing those, I think, as well. Before we had such wonderful devices, I would just take a styrofoam coffee cup, poke a hole with a pencil or a pen in the bottom of the cup, and stick the plunger in that to be the third hand for them to do that. So, and then they could throw it away. You know, just don't do that on my Starbucks cup, because I need that in the morning. But I think those are all things to kind of keep in mind, and the education piece for the patients is absolutely critical for their success. Every time you talk to a contact lens patient is an opportunity to educate and reinforce healthy habits. There's lots of resources available. Scleral Lens Education Society at sclerallens.org has got all kinds of patient support materials and doctor support things. The GPLI.info website has it. You'll find the AOA's and Academy's version of how to disinfect your trial lenses are on there as well. So just a wealth of resources for you that you don't have to reinvent the wheel in generating these materials for your own patients.
Fantastic, thank you. And I did list our emails, so I think, like as we discussed, we're running out of time, but if you have individual questions, certainly more than happy to address those. Just give us an email, and we can help address those other questions that you may have.
Well, again, thank you guys so much. Fantastic lecture. A few things before we go. Please, if you haven't, we had a number of questions come in about where do I kind of get started, find resources. Sclerallens.org is a fantastic resource for both practitioners, fitters of all skill levels, along with your patients. As a practitioner, they'll have forms you can download, fitting guides, tutorial videos on fitting, on educating, insertion, removal, everything in between. We encourage you to become a fellow of the Scleral Lens Society as well. But again, that's scleralens.org. Just a great site that has really no bias to any one lab, but just a great overall resource for scleral lens education. Once you get into the thick of fitting, individual labs have fantastic consultants that can help guide you as far as how their individual contact lenses work. But the Scleral Lens Society is a great starting point for everything from building and coding to fitting, troubleshooting, material selection, and everything in between. There's a webinar on just about everything. Feel free to use these QR codes to scan with your camera on your smartphone, and this one will lead you to information on how to become a fellow or apply to become a fellow. I think we have one more slide there too, and then this is a great guide here too. This has all the fellows from around the world listed on this website on scleralens.org as well. So if you need to find somebody, hey, maybe to help you out, a mentor, somebody in your area who fits scleral lenses, this can be a great resource as well. Thank you all for coming out. We went a little over time tonight. I apologize for that, but there was so much good information. It was definitely worth it. Thank you to our presenters. Everybody stay safe, and we will see you next time.